Welcome to the High Risk Pregnancy Training Academy, where ANMs, medical officers, and specialists come together to learn about high-risk pregnancy conditions, share experiences, and work together to ensure the best health outcomes for mothers and babies. Today, we are learning about the identification, treatment, and management of the high-risk pregnancy condition, fetal growth restriction or FGR. But first, let's meet our expert trainers.
Hello everyone. I am Dr. Karishma Tharyani, a senior obstetrician and gynecologist practicing in New Delhi. Fetal growth restriction is an important public health problem in our country. The high incidence of fetal growth restriction in India is due to younger age at marriage, shorter interdelivery intervals, and maternal macro and micronutrient deficiency. Did you know that FGR babies are more likely to have stillbirths, preterm births, birth asphyxia, hypoglycemia, and sepsis? They are also more likely to have adverse neurodevelopmental outcomes later on in life. So it is extremely important to identify and diagnose FGR early on in pregnancy. To help us understand the complexities of diagnosis and management of fetal growth restriction, we have with us today Dr. Poonam. Welcome, Dr. Poonam.
Thank you, Krishna.
Dr. Poonam is a senior consultant, maternal and fetal health at CFMC New Delhi. So, Dr. Poonam, please tell us what is fetal growth restriction?
So, fetal growth restriction is an entity where the baby fails to grow to its own growth potential. It means that there are certain conditions which does not allow the baby to grow in the environment that the baby has. And this is further looked after by the centiles chart. So every time a baby, which is a fetus, is measured, the growth is put in the growth chart. And according to the centiles of the growth chart, which means that the lower bit, the lower centiles is the 10 centiles. If it is less than the 10 centiles and there are other issues with the Dopplers, these babies are what is called as the growth restricted. Now, the growth restricted fetuses are different from the small for gestational age babies, because small for gestational age babies could just be that the baby is small, but certain babies, they continue to grow in their own growth centiles, which is fine. But when the growth centiles changes, say for example, one baby starts at 58 centiles and drops down to the 10 centiles, that becomes a growth restricted baby, in which we have to be extra careful and more investigations needs to be done, which is the Dopplers. This is very important because the perinatal morbidity and mortality is related to the fetal growth restriction and not to the small for gestational age fetuses.
This is a very important point, Dr. Poonam, that not all small for gestational babies are growth restricted, but most growth restricted babies will be small for gestational age. So, Dr. Poonam, which women are more likely to have growth restricted babies?
So, women whose age is more than 35, the BMI is more than 35, or the BMI is less than 18, so extremes of the BMI, or women who have some medical issues like the chronic hypertension, even diabetes, any antiphospholipid syndromes, any autoimmune disorders. These are the women who are more of the risk of having fetal growth restriction. Even the previous history, if there is a history of preeclampsia or a history of a growth restricted fetuses, makes these women more prone for having a fetal growth restricted fetus.
So Dr. Poonam has again made a very important point here, that if we just remember these risk factors, like women who are at extremes of age, extremes of BMI, or those who have comorbid conditions like high blood pressure, diabetes, history of APLA, or even history of low birth weight or FGR babies in previous pregnancies, we will be able to look at these women with high suspicion, and maybe we'll be able to pick up FGR early on in these women. So, Dr. Poonam, in low-resource settings where imaging modalities like ultrasound and Dopplers are not easily available, how can our ANMs and medical officers help in diagnosing FGR?
So, this starts from the very basics. The ANM has to take the weight, the blood pressure, and the vitals of the patient. And then the obstetric examination, which starts off with a symphysiofundal height, is important. So symphysiofundal height is a measurement of the height of the fundus, which starts from the pubic symphysis, which is the bone in the lower part of the pelvis, to the top end of the fundus. Now, it is important that it is done well. It is also important it is documented, because just one reading is not much of an importance. It is a serial reading which will tell us that this baby is actually growth restricted or not. And any suspicion where the symphysiofundal height or the SFH is not falling within its limits should be referred to at the earliest possible to the tertiary centers.
So if we remember the basics, that is taking a detailed history, doing a thorough examination, and taking the symphysiofundal height properly, we will be able to pick at least some cases of fetal growth restriction. To know more about antenatal abdominal examination, you can have a look at our video on ANC examination, which also includes a demonstration of symphysiofundal height. So Dr. Poonam, if the ANM suspects FGR in a woman, how should she counsel her about it?
So the ANM should tell the lady to balance the diet. The diet has to be more of proteins. She should also emphasize that whenever she lies down, the women should lie down on the left lateral position, because that's the position where the fetus gets the maximum blood supply. The resting is also very important. So emphasis back on the basics, at least 2 hours of rest in the afternoon time, and good amount of rest in the night time. Some amount of exercise is needed as well to keep herself well hydrated. So all these very basic examples of how to nourish herself well would go a long way in making sure the baby also gets the best of the nutrition.
Dr. Poonam, are there any imaging modalities or investigations that help in diagnosing FGR, which our medical officers should know about?
Yeah. So the medical officer should also start from the very basics, right from checking the blood pressure, checking the urine, taking a detailed history, making sure there is no medical disorders or the previous history of any problems. When it comes to the clinical examination, along with this symphysiofundal height, the imaging happens to be one of the best modalities to diagnose the fetal growth restriction in women who are suspected of fetal growth restriction. So when we talk about scanning, it's about looking at the baby in details, making sure there is no other major abnormalities, and then checking the various circumferences of the fetus. In the FGR, there are 2 parameters which is very important from the growth perspective. It is the abdominal circumference and the estimated fetal weight. Both of them have to be plotted in the growth charts, which is the centiles chart. A customized growth chart, if available, is good. Otherwise, the routine growth charts are important. Once it is classified as 5th centiles or 10 centiles, then it is important that the measurement happens every 3 weeks. If need be, it can be 2 weeks as well, but it can't be, and the growth should not be more than, it should not be less than 2 weeks. The reason being, it's important to take the growth and put it on the graph, which is only relevant if it is above 2 weeks' time. Now, when the growth centiles, AC, which is the abdominal circumference or estimated fetal weight, is less than the 10 centiles and the Dopplers are normal, we can say it's a small for gestational age. But if the growth velocity, which is the baby was in the higher centile, then it drops down, or there are changes in the Dopplers, the baby is then classified as the fetal growth restricted.
Okay, so a combination of biometry on ultrasound and Doppler
is important once there is a diagnosis of a fetal growth restriction which is made. Now, clinically also, when we do a symphysiofundal height, there are certain patients where it may not be very easy to calculate the symphysiofundal height according to the to the gestation, because there are certain women who are obese or with fibroids, or even when the baby's position is not longitudinal, that means transversalized. So either of these conditions, symphysiofundal height may not reflect the actual restriction or growth restriction of the baby, which we should all be looking into.
In these women in whom we cannot calculate the symphysis fundal height, it is best to get an imaging like ultrasonography or Doppler done if we are suspecting an FGR,
That's
right?
right. So any suspicion of FGR, it is the ultrasound. Ultrasound will document, will put it on the graph, what are the centiles that the fetus had at that particular time, and then to redo it again in 2 to 3 weeks' time to be able to check for the velocity changes and the Dopplers.
Thank you for simplifying it for us, Dr. Poonam.
Thank you, Karishma.
Dr. Poonam, if the medical officer is suspecting FGR in a pregnant woman, when should he or she refer the patient to a tertiary level hospital?
If the medical officer is suspicious of an FGR, he or she should refer the patient straight to the tertiary health care.
So that means all women in whom FGR is suspected are to be referred to a tertiary care
That's
setting.
right, because the further management is more tuned to ultrasound modality and then timing or the delivery of the patient, which needs a neonatal care unit to be able to take the baby on.
And how are these women managed at a tertiary level hospital by a specialist?
So when these women reach the tertiary care hospitals, they're seen by the doctors where a detailed history is taken, the normal vitals are checked, the blood pressure along with the other parameters. The clinical examination is made, but the entire management is based on the ultrasound findings in these women. As we talked about earlier, the plotting has to happen on the centiles chart, and the Dopplers, the Likert volume needs to be measured. Now, depending on the gestational age, the further management is decided. For women who are less than 34 weeks and the baby is found to be growth restricted, as long as the Dopplers are normal, we allow the pregnancy to continue. If in case there are problems in the Doppler, which is either there are absent Dopplers or reverse Dopplers, or there are changes in the ductus venosus, which is again the Dopplers, or there are changes in the maternal issues, for example, high blood pressure. These are all indications of delivery. If they are less than 34 weeks, the patient gets the single course of steroids, and then the neonatal care is asked to look after. Neonatologist comes and talks to the patient, and the delivery is then planned. Should the delivery be of more than 34 weeks, we need to continue managing the patient with 2 weekly scanning of the growth and weekly Dopplers. When we say the Dopplers in the specialist care or the tertiary care units, it is done by the umbilical artery Dopplers, the middle cerebral artery Dopplers, and the ductus venosus. And depending on each of them, the management is done, which is the delivery. Now, the aim is to continue this delivery to as long as possible, preferably 37 weeks. And these are the parameters which determine what and how long we can prolong the pregnancy. CTG is also added. CTG is the non-stress test, which is also added along with the ultrasound to be able to manage these patients.
So quite a detailed workup is done at a tertiary level hospital.
That's right.
Dr. Poonam, is FGR an indication for emergency delivery always, or are there certain conditions only where emergency delivery may be required?
So emergency delivery is needed first if there is a problem with the maternal condition. For example, it's intractable blood pressure not getting better. There are changes on the NST, on the non-stress test, which means there are bradycardias which needs an emergency delivery, or there are changes in the Dopplers of the fetus. For example, the reversed flow from 30 weeks onwards, or the absent flows from 34 weeks onwards. So all these conditions needs emergency delivery.
Thank you so much, Dr. Poonam, for simplifying this complex topic of fetal growth restriction for our audience.
Thank you, Dr. Karishma.
And as far as our ANMs and medical officers are concerned, I just want to emphasize that please remember, fetal growth restriction is a major public health problem in our country, which is associated with huge perinatal and long-term complications. The diagnosis may sound complicated, requiring the use of ultrasonography or Doppler, But clinical suspicion can be made based on a detailed history and a thorough examination using simple clinical techniques like symphysiofundal height measurement. Once you're suspecting FGR in a pregnant woman, always remember to refer her to a tertiary care center so that she can be managed appropriately by a specialist. To know more about the management of fetal growth restriction, please have a look at our protocols. Thank you.
Thanks to our expert doctors, we now know about identification, management, and treatment of fetal growth restriction in pregnancy. Remember to refer to the protocol for more details.